seminar will be about. Got 3 excellent speakers. They've all been rehearsed and appropriately focused. So I'll ask Marek to lead off, and then Sophie, and then finally Afro. Could I just remind you that there will be a opportunity for a couple of questions after each talk and a more extended Q&A session at the end. Could you please put your questions into the Q&A box at the bottom of your screens, not into the chat box, because I won't be looking at the chat box. I will be looking at the Q&A box to draw out the questions and align them appropriately to avoid repetition. So, Marek, would you like to lead off for us?
Thank you. Thank you, Prof, very much. I need to share my screen. Where is my presentation? Somewhere here. Share. And then we go to show mode. Okay. And then what I need to do, I need to activate the pointer. Pointer option, laser. Good, great. So, ladies and gentlemen, it's great to be with you this evening. Even if we are meeting on a cyberspace, it's a great pleasure. As Prof introduced, we will be all talking about ICP dynamics in idiopathic intracranial hypertension. Previous 2 webinars were absolutely great, but they were devoted to clinical aspects more as a management, surgery, and also pathophysiology of idiopathic intracranial hypertension. Today, we just speak about what we can measure. No theories, no unproven hypotheses, we promise. First, disclosure. Disclosure is a main part. I have the share in licensing software ICM Plus we are using for brain monitoring. An example of this monitoring will be shown during this seminar. We start, and we need to start with short repetition of CSF dynamics. This is a model of Tony Marmaru, who proposed this model in early 1970s, and it's still actual. There is a formation rate. There is a formation rate of cerebrospinal fluid shown here as a current source. Fluid is flowing up to this point where it splits to reabsorption branch and storing branch. Reabsorption branch consists of resistance to CSF outflow, voltage source with sagittal sinus pressure, because the most of reabsorption we believe is to sagittal sinus pressure. And here is a diode showing that this reabsorption is unidirectional. And the compliance consists of non-linear capacitor, and this will be a little bit more discussed in details later. We start from resistance to CSF outflow. This is relationship between cerebrospinal fluid outflow and cerebrospinal fluid pressure or intracranial pressure. Sometimes we will be using intracranial pressure and sometimes cerebrospinal fluid pressure. When pressure increases above sagittal sinus pressure, outflow starts. And this is inversely proportional to resistance to CSF outflow. This is a gradient of this line. Below sagittal sinus pressure, outflow does not exist. A higher distance between CSF pressure and sagittal sinus pressure, higher cerebrospinal fluid outflow. If we plot horizontal line equal to formation of fluid which is approximately 0.3, 0.4 mils per minute, we will see mean intracranial pressure resulting from CSF circulation. And Davson equation is very important because it shows mean intracranial pressure resulting from CSF circulation. It consists from two components: air out, time formation of cerebrospinal fluid. This is a relatively small component. Air out on average is 8 millimeter of mercury per mil per minute, and this 0.3. So 3 millimeter of mercury of intracranial pressure results from flow of cerebrospinal fluid through pachyonic granulation. This component is much higher because if we imagine that intracranial pressure in idiopathic intracranial hypertension is really elevated, 20, 30 millimeter of mercury, and this is only 3, this must represent the most of the intracranial pressure, providing air out is average and formation rate of cerebrospinal fluid is equal to this 0.3 mils per minute. And the compliance. Compliance is described by exponential pressure volume curve. Above certain pressure level, which is called P-opt, curve shows that with increasing volume, relative rise of intracranial pressure is really exponential. Higher so-called elasticity, steeper this exponential part of the curve. It means volume, change in the volume of CSF space produces higher or faster increases, decreases, changes in intracranial pressure. But below P-opt, this line becomes linear. So sometimes we are saying here is a region of poor compensatory ability, and here good compensatory ability. Everything is pulsatile in the brain. Arterial blood pressure, intracranial pressure, also blood flow through big cerebral arteries, here picked up with transcranial Doppler, are pulsatile. So pulsatility of intracranial pressure is very important. We call amplitude of this pulsatile component AMP, and below pressure, the same P-opt, we see that amplitude is not changing with mean intracranial pressure, but above is changing proportionally to mean intracranial pressure. The slope of this amplitude pressure line is equal to elasticity times stroke volume of the blood going to the brain. This intercept point is equal to so-called P0 parameter from the model, and we take this as an estimator, poor estimator of sagittal sinus pressure. But pressure volume curve is more complicated than that. Above certain intracranial pressure level, which we call critical ICP, it bends to the right. What does it mean? It means that the brain receives the extra compliance. This extra compliance is a compliance of collapsing arterial vessels. Intracranial pressure here is very high, cerebral perfusion pressure is very low, that this compliance occur. If we plot amplitude here is this lower breakpoint of amplitude pressure curve, so good compensatory reserve, then increasing, and then above this breakpoint we see decrease in the pulse amplitude. This decrease in the pulse amplitude is associated with this rise of intracranial pressure to very high value when it obstructs normal cerebral blood flow. We calculate very useful parameter called RAP. This is correlation coefficients between intracranial pressure and pulse amplitude. It's equal to 0 when we are below lower limit or P-opt equal to +1 when amplitude is increasing with intracranial pressure and becoming relatively low or even negative when we are above critical intracranial pressure level. So what we measure during infusion study: ICP baseline, amplitude baseline, resistance to CSF outflow, elasticity, and RAP. The rest of the parameters are maybe not that much important. What we need to do, we need to have access to cerebrospinal fluid space, have the trolley with pressure amplifier and infusion pump, plus computer running ICM plus software, and do infusion. And what we measure? We measure baseline intracranial pressure. This is ICP-B baseline. Then when we start infusion, pressure increases to ICP plateau. Resistance to CSF outflow under assumption, very important assumption, that during this infusion until reaching plateau, sagittal sinus pressure is not changing, can be calculated as the difference between plateau minus baseline divided by infusion rate. Notably, here you can see that amplitude of pulse waveform very nicely correlates with mean intracranial pressure. And then we have intracranial pressure, resistance to CSF outflow. We, for a while, forget about elasticity, and then we can say that we have some kind of the roadmap, classification of CSF disorders. Normal ICP and normal resistance to CSF outflow, it's normal CSF circulations. But patients with brain atrophy also can be contained here. Low ICP, but increased resistance to CSF outflow is normal pressure hydrocephalus. Acute hydrocephalus, high ICP, and high resistance to CSF outflow. And we wonder what will be here. You probably guess that it will be idiopathic intracranial hypertension. But both of my colleagues will discuss this more in details. Now we can finish with a repetition of CSF circulation and dynamics, and then we can go through few examples of the monitoring of intracranial pressure. We can monitor intracranial pressure preferably with intraparenchymal transducers overnight. It's the best time. Patients are resting, are asleep. And then most commonly we would see intracranial pressure. This is this yellow trend, relatively constant, relatively stable, and really increased, around 30–40 millimeter of mercury. RAP, compensatory reserve, is also increased, is higher than 0, close to +1, like here, like here, like here. Therefore, it's disturbed compensatory reserve. Our estimator of sagittal sinus pressure, P0, although its estimator is also increased. If the mean value here is 40 millimeter of mercury, mean value of estimator of sagittal sinus pressure is 35–36 millimeter of mercury. But this is not always like that. Here is another patient. Baseline ICP before he gone asleep is around 20 millimeter of mercury, relatively constant. It's increased intracranial pressure, not very much, but baseline increases to 30 millimeter of mercury when he starts his night sleep. And moreover, we see very fast and very high rises of intracranial pressure, vasogenic waves, to 60–70 millimeter of mercury. And moreover, when he was awake again, Intracranial pressure here is stable and even lower than when we started with 10 millimeter of mercury. So you can imagine if we do check of his intracranial pressure with lumbar puncture here in the morning, everybody is happy. Here will be 10 millimeter of mercury. And then we would miss these high elevations of intracranial pressure, which really characterize the patients. Notably, RAP is close to +1 all the time. Pulse amplitude reacts to changes in mean intracranial pressure. Every plateau wave, every vasogenic elevation of intracranial pressure has its equivalent rise in pulse amplitude of intracranial pressure. And here is another example, even stranger. However, the pressure is elevated almost always, but we start with around 40 millimeter of mercury. Then we see the longer period of pressure around 20 millimeter of mercury. Then 40 millimeter of mercury again, deep to 20 millimeter of mercury, and some increases to 60 millimeter of mercury, also of vasogenic origin. It's tempting to say that these systems got the three stable pressure states, 20, 40, and 60 millimeter of mercury. The 60 millimeter of mercury is here, and then these are probably the same vasogenic waves as in the previous patients. 20 and 40 are steady states which are characteristic for these patients. And it is strange to observe them. We can see them very, very occasionally. I have, I think, only 2 examples over 30 years of monitoring various pressures in the various patients like that. If you look at this recording, somebody would say, this is probably a broken transducer. It produced some kind of the ups and downs. But if we look at the shorter period of this recording, we can see the reverberation of intracranial pressure from 0 millimeter of mercury to 40 millimeter of mercury, down and up, quite regular. Frequency of these waves was 1 minute. That's very, very interesting. This system is unstable. It generates the waves between 2 steady states, 0 and 40 millimeter of mercury, but it cannot reach a steady state, either this low or either this high. It reverberates between upper and lower steady state. Zofia will tell you a little bit about what may be an explanation for such a phenomenon. Another example, this is also overnight monitoring with ICP and amplitude. So here we paid attention to intracranial pressure and pulse amplitude. If we plot amplitude versus mean intracranial pressure, we will see this sloping amplitude pressure line with maybe a little bit distortion at the high intracranial pressure, but we cannot see this very nicely. If we plot RAP versus intracranial pressure, we can see how compensatory reserve changes when ICP changes. When ICP is low, RAP is close to +1, and that shows poor compensatory reserve. When ICP is higher, RAP tends to go to 0 and even to negative values. And this shows that starting from this level or this level, intracranial pressure reaches or touches the critical level above which cerebral blood flow starts to be impaired. And this another example, this is this time attempt to do infusion study. We noticed baseline value 40 millimeter of mercury, so obviously we didn't do any infusion to rise ICP further, but we did several drainages, stepwise drainages of cerebrospinal fluid, which produce decrease in intracranial pressure. If in such a case we plot RAP versus intracranial pressure, we can see that at the low level of intracranial pressure, we have good compensatory reserve, low RAP, then it's a bad compensatory reserve. And then at the very high levels of intracranial pressure, these are somewhere here, we see that RAP is going to negative values. Once again, impairment of normal cerebral blood flow, probably subacute ischemia. Another infusion study, this time we started from 20 millimeter of mercury. So we had the opportunity to do infusion with low rate, 1 mils per minute, to rise intracranial pressure to 30 millimeter of mercury. And then did the drainage of cerebrospinal fluid, which brought the ICP to 10 millimeter of mercury. When we plotted relationship between pulse amplitude and mean intracranial pressure, we looked at this and then we saw the two breakpoints, lower breakpoint and upper breakpoint of pulse amplitude relationship on mean intracranial pressure. And then finally, this is another example, this time in a child. We noticed baseline pressure 40 millimeter of mercury. The study was done under general anesthesia, 40 millimeter of mercury. So we didn't do any infusion, just a series of the drainages. Here ICP was measured. And then what we noticed, at the 40 millimeter of mercury, RAP was negative. So we were already above critical thresholds for intracranial pressure. Then when we started lowering intracranial pressure, RAP increased to +1, and then the system shifted to this low compensatory reserve state, but without disturbance of cerebral blood flow. And then we looked at the other parameters. ICP was 40 millimeter of mercury, and arterial blood pressure was only 70 millimeter of mercury. Therefore, his cerebral perfusion pressure was only 30 millimeter of mercury, and it was associated with negative RAP. This shows that we need to have a look at cerebral perfusion pressure in those patients, because such a low cerebral perfusion pressure for example, head-injured patients in acute states is a terminal cerebral perfusion pressure. These patients may have continuous sub-acute cerebral ischemia, and then they suffer from clinical symptoms. They frequently complain for so-called foggy brain, fog in the brain. In conclusion, ICP over longer time may be unstable in idiopathic intracranial hypertension. And this instability may question validity of lumbar puncture measurements. Evidence of approaching and even breaching critical ICP may be visible and quite frequently. And we need to take into account cerebral perfusion pressure. So whenever we measure intracranial pressure, we also please measure ABP non-invasively and make a quick calculation what cerebral perfusion pressure is. This very low cerebral perfusion pressure may be responsible for this phenomenon of foggy brain. Thank you very much.
Thanks very much, Marek. Just a number of questions. This concept of stable states, where you say that the intracranial pressure or CSF pressure appears to transition between various stable states. We heard in the first two seminars about the fact that many patients with IIH have actually got stenosis of the transverse sinuses, which can be associated with pulse alternatives. To what extent would you like to hypothesize as to whether or not this transitioning between stable states may just reflect changes in the extent of the transverse sinus stenosis, which we know in many of these patients is reversible. To what extent do you think the stenosis are varying?
I think, Prof, it is one of the points Zofia is going to talk about. So, for the sake of the time, I think that we can discuss this.
Okay, no, we can defer that
after her presentation.
One other methodological question: we know there are some patients who hyperventilate. They know how to, if they overbreathe, they reduce their CO2, and it gets rid of the headache and helps them. They're often dismissed as functional because people see them hyperventilating. In fact, what they've learned and not realized is physiology. I memean, to what extent do you think we should be monitoring in these patients with very high pressures? Do you think we should be looking at their end tidal or their CO2 levels?
Any kind of the measurements of monitoring is useful in those patients. We didn't do this. We sometimes measure end tidal CO2 in patients with different problems. And this is very, very useful because intracranial pressure is really very much affected by level of PaCO2. So unfortunately, I don't have example, I don't have experience in patients with idiopathic intracranial hypertension.
Okay. Well, thanks very much, Mark. There are no questions coming up at the moment. So, Sophie, would you like to take over?
Hello, everybody. About referring to the question about CO2, but I think it will be useful to discuss this by the end of the presentation. Things might be more clear. In my turn, I would address a few issues. The pathophysiology aspect, is it sinus blockage or collapse? ICP versus sagittal sinus pressure, some observations plus statistics, a need to correct a route in idiopathic intracranial hypertension, and the effect of sinus collapse, is it specific to IIH? The pathophysiology of IIH is not obvious. The CSF's hypersecretion is one of the hypotheses. It has been highlighted in a previous webinar on IIH. The fact is that patient may improve after acetazolamide, which reduces CSF production, but this concept has not been verified by independent clinical measurements so far. Brain edema has not been confirmed by clinical brain imaging hitherto. Impaired CSF absorption was not verified by the measurements neither. Furthermore, our results don't support this hypothesis. I will discuss it later. The fourth assumption that cerebral venous blood outflow is to blame requires closer insights. Transverse sinus in patients with IIH can be blocked due to thrombosis. It can be also collapsible. Externally operated pressure, the ICP, could bring to a close venous outflow. In turn, collapse of the venous outflow will produce fast rise of ICP. Such a collapse would happen at the most distal part of transverse sinus, where the gradient of ICP and sinus pressure is greatest. Dr. Nick Higgins, Professor John Pickard, and Brian Owler have pioneered transverse venous stenting surgery to prevent collapsing sinus and subsequent rise in ICP. Observation of pressure gradient along the sinuses has been documented for a while. This is a recording of sinus pressure during retrograde cerebral venography. The pressure sensor was shifted through the stenotic section of transverse sinus and revealed a significant sudden drop in pressure when passing through the stenotic barrier. We investigated 10 patients diagnosed towards IIH. 9 were IIH patients, and 1 patient after mild traumatic brain injury with stubborn headaches. The standard clinical investigation was used, lumbar CSF infusion study and direct retrograde cerebral venography. By performing these 2 procedures at the same time, we had an opportunity to monitor CSF pressure and sagittal sinus pressure simultaneously. The CSF pressure during infusion study shows usual profile. Probably the most interesting thing was to observe both pressures concomitantly throughout the procedure. We investigated how CSF pressure and sagittal sinus pressure were correlated at different stages of the infusion test. That is, at the steady state of the baseline, during raise of both pressures in response to the infusion, and at the phase of plateau, that is another steady state, but with forced increase in pressure due to infusion. After infusion was done, the pressure decreased in both pressures decreased. During baseline, CSF pressure was elevated, but stable. Here we can see only 1 temporary vasogenic increase. Sagittal sinus pressure also elevated, but little bit lower than ICP. During infusion phase, ICP started to rise to reach a plateau. After some time, sagittal sinus pressure followed the course of ICP. And after the infusion, both pressure decreased together. First, we look into the relationship between 2 pressures for an individual patient. Not only mean values of pressure were well synchronized, but also slow vasogenic waves, which are recorded here in both signals, were strongly correlated. And pulse waveforms of ICP and sagittal sinus pressure were coupled. The waves converge close to the diastolic part of the heart cycle and diverge during the systolic part. The linear relationship between mean pressure that Marek is talking about and pulse amplitude look the same in ICP and sinus pressure. The slope of this line was a little bit greater for ICP signal than for sinus pressure. In a few patients, after the end of infusion, we performed deep drainage of CSF with cerebrospinal fluid with additional monitoring of jugular vein pressure, here marked with a dotted line. Here is cerebrospinal fluid pressure, this is sagittal sinus pressure, and dotted line jugular venous pressure on both trends. CSF pressure and here is the part of this was infusion part, and we performed drainage. So CSF pressure during drainage could decrease below jugular venous pressure, but sinus pressure always stayed above. At this very low pressure range below jugular venous pressure, the coupling between sagittal sinus pressure and CSF pressure was interrupted. This can explain a temporary improvement after lumbar puncture. Also, the relief of clinical symptoms after shunting may have similar mechanism. So positive feedback loop between rise ICP and rise SSP can be observed for higher pressure range, but can be interrupted in lower ranges. And these were observations in individual patients. The next question is, how convergent are they in between patients? Baseline pressures before start of infusion correlated very well. All patients but 1 had elevated pressure about 18 millimeters of mercury for ICP. The correlation coefficient was sky high. During infusion on a plateau level, correlation is still high. Note that the infusion was performed only in 6 patients because the baseline in 4 hours remaining force, the baseline was too high to infuse fluid. And similarly, pulse amplitudes of both signals were highly correlated. So to summarize, the baseline ICP was in all cases elevated and always a little bit greater than sagittal sinus pressure. During the plateau phase of infusion, both pressures increased, but ICP increased more than sagittal sinus pressure. All increases were significant. Now we look at the difference between cerebrospinal fluid pressure and sagittal sinus pressure. During infusion, the difference increases significantly as a result of greater rise of ICP. It implies that resistance to CSF outflow is observed in IIH, even though sagittal sinus pressure does not remain constant. However, correct assessment of a route is not possible without monitoring of sagittal sinus pressure, and the normal formula needs a modification. We compared air out in IIH patients with those with normal CSF dynamics. We made 2 attempts. First, air out for IIH patient was calculated without adjustment for rising sinus pressure, and IIH air out seems to be higher than normal. But when air out for IIH patient is calculated with correction for increasing sagittal sinus pressure, it tends to be lower than in normals. The question arises whether such coupling between ICP and sagittal sinus pressure can be seen not only in IIH, but in normal pressure hydrocephalus or other conditions. If so, all our attempts to calculate the route are in vain. This monitoring in an individual patient who did not have IIH confirmed that the sagittal sinus pressure, we can see here the red line, this is monitoring during infusion study. So sagittal ICP increases in response to the infusion, but sagittal sinus pressure remain constant, stable during the whole procedure. So the sinus pressure is not affected by changes in ICP. Similarly here, the pulsation in ICP are not reflected in sagittal sinus pressure. So finally, we can try to interpret the strange fluctuation of ICP in one of our IIH patients that Marek was showing previously. ICP was not stable, but fluctuating between 0 and around 30 millimeters of mercury. Unfortunately, we don't have recording of sagittal sinus pressure, but we may hypothesize about this unstable positive feedback between ICP and sagittal sinus pressure. Increasing ICP causes the collapse of venous outflow, which in turn causes further increase in ICP. Collapsed sinus causes further rise in SSP, resulting in opening of the venous passage. ICP decreases again. Because of an unstable nature of this positive feedback, this collapsing and reopening was repetitive. Such a picture, however, can be observed very often. Very rarely, not very often, rarely. It brings us to the conclusion. In patients with visible stenosis of transverse sinus, strong coupling between ICP and sagittal sinus pressure is observed. The fact that sagittal sinus pressure rises during infusion test implies a correction in calculation of air out. In IIH, real air out seems to be low. This suggests a conclusion that IIH is not a disease of CSF circulation. The coupling between sagittal sinus pressure and ICP seems specific to a patient with IIH, not observed in other conditions. In IIH, sagittal sinus pressure and ICP coupling has a character of dynamic positive feedback. It may result in a significant increase in ICP pulsatility. Again, the dynamic aspect of IIH needs to be highlighted. And one more conclusion, probably more appropriate by the end of our webinar, is to be aware that pseudotumor cerebri is multifactorial problem. Therefore, all doctors or specialists treating and trying to investigate, like neurologists, ophthalmologists, radiologists, people like us, brave physics, we have to try understand better each other, communicate more each other, and cooperate more each other. Thank you. That's all for me.
Thanks very much, Sophie. I think your third conclusion that IIH is not a disease of the CSF circulation, I think it's best to, I think that's very controversial, really. How do you account for the fact that various investigations show that there is too much CSF in the subarachnoid space, in the extracerebral component, far too much CSF? And the fact is that this chronic increase in CSF and CSF pressure can give rise to CSF leaks, formation of CSF venous fistula around the spine, and spontaneous intracranial hypotension. You know, there is a problem with CSF getting out of the head. And can I just come back and challenge you about Davson's equation? I mean, Davson did his work in rabbits, which do not collapse their sinuses when you raise the pressure, which he showed. But he was always at pains to point out there is actually a gradient of pressures within the sagittal sinus. So if you measure the pressure more anterior at the front of the head and then posteriorly and then below level of the stenosis, you get different values of what it constitutes the intracranial venous pressure. So why focus on just one value for the venous pressure? It seems as if your interpretation is saying there is something absolute about Davson's equation, when in fact you should be rethinking the appropriateness of Davson's equation rather than trying to extrapolate from it to say there's not actually a problem with CSF exiting the head.
Prof, it's an excellent question. That's and probably for another lecture. My conclusion about that IIH is not clearly, maybe I should have put it this way, is because from the perspective of treatment, because if it is more, if we assess the CSF dynamics, treatment of the shunt, by treatment with the shunt, we interfere in changing CSF dynamics. So if the outflow of cerebrospinal fluid is normal, if the resistance is normal, the shunt wouldn't change much. However, so if the resistance is clearly increased, this indicates that this is more like problem of CSF circulation. However, this problem with increased production with the venous collapsibility, probably they create this dynamics positive feedback. A bit of increase of production some vasogenic increases of ICP during the REM phase of sleep may cause collapsing of venous outflow, and then this positive feedback loop may start to increase ICP. I quite agree. Just the measurements are very difficult and not very common. We've done the best from what we've done.
And moreover, Prof, I think that we've been talking about this positive feedback loop. Positive feedback loop in theory of systems not always produce generations. The system may be locked in a high pressure state when transverse sinus is collapsed, and undoubtedly intracranial pressure is related to this value of sagittal sinus pressure we presented today. And also in a low state, when the sagittal sinus opens and intracranial pressure starts to settle down to 10 millimeter of mercury, as I showed on this example. Our lecture today, our webinar, is based on relatively slim material. So these should be treated more as observation than definite proofs. One thing is sure, that when we measure resistance to CSF outflow and take correction to changing sagittal sinus pressure, this value is low, lower than in normal controls.
Okay. Right, well, we've got some other questions coming, but we'll take those at the end, shall we? Shall we move on to Aphrodite?
Yes, sir.
So,
1 second, I'm just sharing my screen. So, yep. Right. Okay, so. And I'm just going to get my pointer as well. So, okay, so good afternoon for me. I'm Aphrodite. So I'll be speaking about some more ICP dynamics in IIH. Specifically, I'll be talking about our pediatric cases in Addenbrooke's, the ones that we've seen. I'll be discussing a lot about the appropriate methodology that we've, at least from experience, reported in measuring and monitoring intracranial pressure. Why we don't prefer lumbar manometry, about some advances and some ways of progressing into non-invasive ICP with different methodologies, and then we'll focus a bit on pathophysiology of IIH, specifically Davson's equation, as well as implications in adult IIH. So I'm aware this is a webinar. I'm afraid we can't give a whole talk about what we know in pediatric IIH because we don't know a lot. We've only had a small, one little study of 31 patients in Addenbrooke's that we've recently published. So we've reported and we've studied about 31 patients being pediatric IIH that are presented in our center for evaluation. And from these, we aim to kind of understand how the current diagnostic criteria, so the Friedman criteria, correspond, or at least what they can show us about the CSF dynamics of these children. Specifically using the Friedman classification into definite, probable, and not IIH. We used these groups, so 13, 13, and 5 children, to look into their dynamics. As you can see here, as it comes to clinical information, all of these children in the definite probable group had to have papilledema, although there were some children in group C, of course, without papilledema. Again, in relation to some clinical information, not all of the children were obese, but the majority of the children were obese, and they had all the features that we classically associate with IIH, including, for example, headache, some features of raised ICP, but mainly other things as well that we associate with red flags. Now, what we've noticed and what we describe in these children, as well as most of the times we do ICP monitoring, is that ICP is not a static number and a snapshot number. See here, we have this recording from a child. The initial opening ICP was about 30 to 35 millimeters of mercury. We see already here within a 20-minute recording that this pressure goes down to about 20 to 25 millimeters of mercury. So that's a 10 millimeter mercury difference within just a short period of monitoring. And using this as number, as we can see, can lead to various misleading classifications in everyday practice. Now, what we also saw was there are some characteristic CSF dynamics for each group. Of course, because of the definition, the baseline pressure is raised in the definite IIH group, but we can see that in terms of CSF compensatory reserve and compliance, these children also tended to have what we have here as high elasticity, which means like less compliant brains, and therefore what we can say simply as stiffer brains. Analytically, we can see here that we have raised pressure at baseline in the definite group. So this is the definite group, this is the probable group, and this is the group classified as no IIH. So this is the pressure at baseline. It's always raised because of the definition. But we can see that the pressure doesn't really stratify between groups, as in like not IIH and probable IIH. Similarly, the sagittal sinus pressure was estimated as quite raised in the definite IIH group, but this is an estimated sagittal sinus pressure that we can't measure invasively in children, at least currently. So other parameters that we measure, as we said, is the compensatory parameters. So interestingly, we notice here that elasticity is raised both in the definite group and in the probable group. So regardless of how high the pressure was, we noticed that both these groups had stiffer brains, and therefore we can interpret this in different ways, but the fact that they had symptoms plus some abnormality in the compliance of their CSF space and brain could be possibly something to look into. And similarly, we notice a tendency into depleted space in the brain. There's not a lot of space in both the definitive group and the probable group. So overall, what we can see here as an example of definite IIH in pediatric patients is that they have this pattern of raised CSF pressure. Of course, there's a, as we said, a definition of raised pressure over 20 millimeters of mercury in this group. We also notice depleted compensatory reserve, as highlighted here by a high RAP, which is the measurement of compensatory reserve. And as we said, they have stiffer brains. Now, as we said, there is, so the Friedman classification in comparison with our infusion test showed that there is a correspondence in the patterns of both the CSF dynamics and the clinical presentation and clinical classification. However, it was not 100% an agreement. What we did notice were, for example, some children, we saw an example earlier, but this is a child that was classified as no IIH. However, we see here a pressure of over 40 millimeters of mercury that can be quite concerning. Sometimes, of course, these children can't be infused, but when we started draining CSF, we can see that, if anything, they started looking more healthy and more normal in terms of CSF dynamics, because initially their RAP was negative, and then they started going back to a positive RAP. What this means is that in the threshold here of a critical ICP we have described before, once this is exceeded, these patients start to have a collapse of their cerebrovascular bed, as is shown here by the negative relationship with pressure and amplitude. And that means that their cerebral perfusion is starting to be less than optimal. Specifically, as we said here, this is the point where the relationship becomes negative instead of positive of the amplitude and the pressure. And this would correspond to this point of the critical intracranial pressure. So it would be interesting to think why someone who is possibly not perfusing the brain as they should, especially at a pediatric age, is considered as no IIH or as something normal, or whether, again, this should be investigated into further. In relationship to when we say elasticity and stiffer brain, again, these children that are thought to have probable IIH, but we're not really certain because they don't meet the exact pressure, we can see that the fact that they have stiffer brains, again, means that they're more susceptible to steep increases in pressure with minimal perturbation of any issue, for example, minimal increase in the volume of CSF or minimal increase of minimal disturbance of any balance in their brain. And again, that could maybe explain why they might be more symptomatic when we can't find any obvious disturbance, especially when we're just looking into the ICP as a number. So in relationship to pediatric IIH, as we said, we don't have a lot of data. I'm afraid that, yes, we all know it's very rare and very difficult to accumulate lots of evidence about these patients, but we at least can say that if we're going to confirm and measure the pressure as elevated, it would be good to use appropriate ICP monitoring to confirm an appropriate methodology to confirm that. And then, of course, it would be good, we have already accumulated and studied more patients to look into more things that influence intracranial pressure in these children. We can see that it is a feature of these patients that they have poor brain compliance, shown by increased elasticity, so they have stiff brains. We're planning to look into how these pediatric IIH patients could be different from the adult IIH patients, and then infusion tests are a useful tool into letting us look into those prepubertal brains. We can see that whilst a lot of the children are also obese, similarly to the adults with IIH, it is not always a contributing factor, or at least a causal factor definitely in IIH. And because of these problems with, which we highlighted with cerebral perfusion, instead of, yes, focusing on vision, of course, in IIH is really important, and it's good that we target vision as one of the successful outcomes of IIH, but it would be important in children of developmental age, school age, to start looking into possibly their cognitive performance with cognitive assessments and how this could influence their diagnosis and management. Now, moving on to further assessment of ICP and ICP dynamics in IIH. As we've shown earlier, it is difficult to use just intracranial pressure to study CSF disorders. In the context of hydrocephalus, we can add, because we know that there's a circulatory component, we can add resistance. And then in conditions such as IIH, where we know that there's high pressure, possibly normal, at least measured as normal resistance, we can add other parameters. As we saw in IIH, there is disturbed compensatory reserve, there is disturbed compliance. So adding more parameters into the pressure as a number would be very important into investigating these conditions. Again, this is to show the limitations of using ICP as a number to classify patients. We only had 10 patients in our cohort, pediatric IIH, that were referred from other hospitals to Addenbrooke's. These patients had a lumbar puncture before they came to us to have another measurement of their CSF pressure. We can see here that there's a very poor correlation between the number from the lumbar puncture and the infusion test. This is not to highlight that if we were to perform this test at the exact same time, the number would not be exactly the same. It would be exactly the same. But as we said, if the pressure now we want to use it is about 15, and then in 2 months we take it again and it's about 25, that changes a lot. And that shows us that we should consider not just doing isolated pressure measurements into trying to classify IIH or any other CSF disorder. Speaking of other CSF disorders, this is a hydrocephalus patient from a previous publication where, again, lumbar punctures are inappropriate, just snapshot points would just show, for example, here, normal pressures. But of course, we can see that when we don't monitor ICP over long term, we can miss very important disturbances. This patient has, as you can see here, quite significant plateau waves of intracranial pressure over 60 millimeters of mercury. And the lumbar manometer could just estimate maybe sometimes a pressure of 18 millimeters of mercury, what we perceive as normal, and end up not treating the patient. Understanding now the limitations of using ICP as a snapshot measurement, and understanding the importance of using like appropriate methodology in estimating ICP, we can move on to new era and move on to non-invasive ICP. In IIH, we do not have currently a lot of data in non-invasive ICP, but this is data from transcranial Doppler, where just to compare the, to fine-tune the methodology with lumbar puncture, we can see that we can reliably assess ICP using transcranial Doppler in these patients. The number can be just as reliable as lumbar puncture. Transcranial Doppler is a good non-invasive method for measuring ICP because it can also provide us with information about cerebral blood flow and cerebrovascular reactivity. And it can be a useful tool to monitor these patients over time instead of, again, obtaining snapshot measurements. Similarly, optic nerve sheath diameter, we do not have currently from our group that we know of any ONSD measurements in IIH patients, pediatric or adult. However, we know that with optic nerve sheath diameter, we can again estimate pressure non-invasively. This is some data from traumatic brain injury patients that show a good correlation of elevated pressure with an optic nerve sheath diameter that is increased, usually over 5.5 millimeters. Of course, we know that used appropriately, in this specific methodology for TBI patients, ONSD was used to monitor the patients over a period of time and not just to estimate snapshot measurements of pressure. And therefore, it worked really well in monitoring the patients clinically. Of course, remember that TBI is an acute pathology and IIH is not. So whenever one applies this methodology, should be aware of their limitations and what they show us and why we are performing them. In the new era with our latest implantable telemetric ICP readers, we have the ability to monitor these patients again over time, which is very useful by implanted devices. Of course, we know that we haven't perfected telemetric ICP monitoring yet, but especially after treatment, for example, after shunting, this is an example of a patient from Chicago. So we can monitor again whether the pressure is higher than we want it, or maybe sometimes if it's draining too much. But it is, again, a very promising method to think about in the future that allows us very good long-term monitoring of ICP. Now, getting into pathophysiology again and Davson's equation, what we talked about earlier is indeed Hugh Davson performed his early experiments in the 70s, and it was on rabbits. It's not to say that this equation hasn't been verified in humans, especially we know that from early infusion test results. However, we know that physiologically, the sagittal sinus pressure, both in rabbits and in humans, is not meant to be not constant. So it's not meant to collapse with the increase in pressure, it's meant to be constant. And therefore, in IIH, since we talked about earlier that it's not always constant, and especially it is coupled with IIH and it can change, we can easily simplify Davson's equation and change it to account for this coupling of the IIH and the sagittal sinus pressure. So from the patients that you saw earlier from Zofia, we did apply linear regression in order to simplify this equation. And we substituted sagittal sinus pressure as an expression of ICP via this regression line. We know that now this regression line is dependent mainly on ICP and the central venous pressure, which is the other parameter. And therefore, substituting this and simplifying this equation gives us a result of understanding why the intracranial pressure is increased in these patients. Estimated from our 10 patients with IIH and sagittal sinus pressure, we can see that the average ICP in IIH is about 27 millimeters of mercury. And that, again, in this specific 10 patients that we selected to study, shows how a pathophysiological mechanism can explain the question that we've been talking about: why is IIH so raised in IIH? And in this case, we say that it's because of this coupling of the sagittal sinus pressure and the CSF pressure and this constant feedback loop mechanism that is created as a result. In similar ways, again, using these physiological estimates through Davson equation, we can see that knowing that the sagittal sinus pressure is increased in IIH, therefore knowing that it's one of the main pathologies at least, and pathophysiologies in IIH, we can see that if, for example, we were to think that it's the resistance to CSF outflow that is raised as a cause rather than a consequence, we could see that it would not necessarily account for that significant increase in IH that we see in IH patients. Therefore, yes, there might be a raised resistance, so circulatory component secondary to the very high, for example, sagittal sinus pressure because there is sinus stenosis. However, it won't explain fully why the ICP is raised without the component of the sagittal sinus pressure. In normal individuals, for example, or at least in individuals with normal sagittal sinus pressure, for example, in hydrocephalus, we can explain the raised ICP if the resistance is raised enough alone. Similarly, again, knowing that the sagittal sinus pressure is raised in IH, an increase in the production of CSF, as sometimes has been hypothesized in IH, would not explain this raised ICP. Again, in different situations, for example, as we said, different neonatal pathologies, yes, a significant increase in CSF production would drive an increase in ICP. However, not in a case where we know that the sagittal sinus pressure is increased and or coupled with the CSF pressure. And again, that would be important into looking into further therapies and investigations in IH in the future. So using the pathophysiology and the pathophysiological understanding of the CSF circulation could help us again design trials in a more targeted and mechanistic way. So to conclude, we've talked about a lot of things today. So I'm going to summarize pretty much everything. So we talked about how it is important to use the right methodology and use a good long-term averaging of ICP in order to confirm it as elevated or to understand its dynamics. We've seen earlier from Sophia that there are cases where there is a dynamic coupling between this intracranial pressure and the sagittal sinus pressure, both statically at baseline and also dynamically during infusion. We can see sometimes that from our measurements that have some limitations of their own, there is normal resistance to CSF outflow, but we can see that there is depleted compensatory reserve. So that could show again that there is possibly more volume, as we said in IH, but we know that there is a good pathophysiological characterization of the disturbance via infusion tests. We also know that the pulsatility of these pressures increased in IH, and we can see that during infusion. And because of this specific coupling between sagittal sinus pressure and CSF pressure, if we target this at the root of the mechanism of the problem via stenting or via shunting, depending on which of these two options the pathology is amenable, we can basically reduce this problem and then treat the patient. And of course, as we said, moving into the new era in advancing non-invasive ICP methodology, we can use ultrasound, specifically transcranial Doppler, and we can use other ways of monitoring ICP non-invasively. But all of those need to take into account the importance and the main points of CSF pathophysiology and physiology that we've talked about today in order to be applied in a proper targeted way. Thank you very much. And thank you to everyone who's done IIH research in the past many years in the lab. Thank you.
Thanks very much, Aphrodite. That was a fantastic talk. All three talks very provocative. One question from Dieter Theis has come up. Could increasing the central venous pressure by increasing intravascular volume have a positive effect on intracranial pressure by opening the collapsed venous sinuses? Just a clinical point, in patients with IH who've got pulsed alternatives, if you gently compress the internal jugular vein, then often the pulsed alternatives will disappear because you are raising jugular venous pressure, and therefore what happens is the stenosis reverses. It's a very good clinical test. So yes, you're absolutely right, Dieter, that would help. Jalal Naja raised the question about cerebral venous sinus thrombosis, very topical given COVID-19. the difference in CSF dynamics between deep venous sinus thrombosis and sagittal sinus thrombosis. That's probably unfair to ask our speakers to think, unless, Marek, do you want to address that?
No, I mean, as I said, we would not be talking about the new theories and hypotheses. So we didn't measure this, unfortunately. So I cannot answer really. I don't know what is the difference. Must be difference. And I think that the patients, the people studying CSF and venous outflow dynamics with such a techniques like phase contrast MRI would have possibility to answer these questions.
Yeah. Okay. So, what is the biological basis for the reduced compliance in IIH?
Compliance is very much general lumped parameter, really. We say compliance thinking about that the brain is somewhere trapped into the rigid skull. And the compliance we are measuring, for example, during infusion study, it's a really compliance of venous bed because it's a low pressure bed. Therefore, if we think that if we close the outflow, venous outflow, we are filling venous bed with additional volume, and this way we are reducing compensatory reserve.
Right. And what would you say to those people who write guidelines, both for adults and pediatrics with IIH, when they say there is a magic threshold of 20 or 25 millimeters of mercury for the diagnosis? Do you think they should revise their guidelines? I'm trying to provoke somebody online who's a writer of guidelines to respond.
I think that, you know, like in guidelines, the guidelines are average for all our patients. Our answer to this is it's better to measure than to guess. It's very important to measure intracranial pressure, as we try to show during our webinar. And without measurement, guessing, just only guessing, we may get a big error of judgment, which may implicate optimal management of the patient.
And if I may add also, it's on the very important aspect, the dynamic of intracranial pressure, because we have demonstrated, it was just measured examples of patients. Patients with mean intracranial pressure from LP around 20, but with big elevations caused of vascular origin during the night. So again, it's an argument to not to keep to strictly to the clear thresholds.
Yeah, we need to understand that pressure, intracranial pressure, is more than a number, and particularly in disease like intracranial hypertension. Intracranial pressure is here in the title, in the name of the disease. We need to take into account these problems. It may be very, very much unstable.
And if I may say one thing, that again, this is, I understand, multifactorial syndrome, but these different factors, again, they interfere. Like production, increased production may cause increase of ICP, this may cause collapsing of venous outflow, it may create positive feedback. So we can't focus on one aspect and look at the more factors and how they interact between each other.
Right, so we've got one of the doyens of CSF, Harold Racate. I suppose everybody knows Harold. As to the guidelines, you must treat what's appearing to the patient without incapacitating headaches or papilledema, do not need intervention due to the high ICP or low compliance. Well, we'd all agree with that. And that also includes not over-treating the patient with too many drugs with all their side effects. But they're very high ICP. I mean, why aren't these patients unconscious? Standard question.
They are not unconscious, they are conscious. I mean, the examples we showed today showed the cerebral perfusion pressure very, very low. Cerebral perfusion pressure 30 millimeter of mercury. It's a lethal, really deeply ischemic level of cerebral perfusion pressure in acute cases. And there is no questions about this, I hope. It very strictly correlates with fatal outcome following, for example, traumatic brain injury or subarachnoid hemorrhage. So we cannot neglect, we obviously has a right and the great reasons that we are treating patients, not treating numbers. Explanation of pathophysiology with such a crucial parameters like low cerebral perfusion pressure. We don't measure cerebral blood flow, unfortunately. Mandates additional insight of disease. For example, like presentation of patients with idiopathic intracranial hypertension. They complain, I have fog in the brain. My brain is foggy. It may indicate, in my opinion, that they continuously live on a level of high ICP and low cerebral perfusion pressure with subacute ischemia, sort of.
I mean, the reality is there's no distortion of the brainstem, which probably explains why there's no change in conscious level. And when people have actually measured cerebral blood flow properly with perfusion studies, they've not been able really to show, they're pretty old studies now, which need to be repeated. They've not really shown a reduction in cerebral blood flow in many parts of the brain. So these brains are otherwise healthy, so they're autoregulating, which is probably why they can tolerate chronically such reductions in cerebral perfusion pressure.
Yes, and vascular bed is very heterogeneous.
Very heterogeneous, yeah. So, I think we're coming to the end of the questions that are being asked. It's a fascinating area. I think time has come, to wrap up and just say thank you very much to our three speakers, to those people who've contributed questions. And I hope it stimulated people to go and look at some of these problems, which are, as you can see, controversial and not in no way have they been answered yet. Lots of things to think about.
Thank you very much.
Thank you very much to everybody.
Thank you.
Okay.